Good morning. Welcome back to day 3 of the conference. I'm really excited to introduce Dr. Ayla Peleg, who is a geriatrician and palliative care physician here at Mount Sinai. She's director of the palliative care consult service at Mount Sinai Hospital and leads Geri Talk, which is a powered by Vital Talk serious illness communication course for our Geri and PAL clinicians here. Dr. Peleg trained in geriatrics and palliative medicine here at Mount Sinai for fellowship after completing her residency at Cook County Hospital in Rush in Chicago. Her work focuses on strengthening core palliative care skills across all disciplines, and it is my great pleasure to welcome her to start off our course this morning. Thank you so much, Ayla.
Thank you, Molly. Good morning, everyone. I'm very excited to be here with you today to talk about one of my favorite topics of serious illness communication. So we're going to spend the next 40 minutes or so talking about a large topic and trying to condense as much information in as we can in a helpful way for all of you. I have, as I go to the next slide, no financial disclosures. Here's some keywords that we'll be going through today. And really what I'm hoping to go through in a very big topic is going through some of the evidence and literature that demonstrates the importance of good communication and give you guys some concrete scales to acquire a roadmap for leading goals of care conversations. And the hope of that is really to align what patients' values are and to come up with treatment decisions for those values. Some of you may have heard some of these acronyms or some of these frameworks. So I'm hoping it will, if you've heard it before, it will be kind of a refresher. And at different points in your clinical career, you can always take something away a little bit different. So hopefully you'll all get something from this session today. So what is serious illness? Serious illness is a health condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life, or excessively strains their caregivers. A lot of you work with patients in geriatrics and palliative care that have serious illnesses. And I want to just emphasize that when we talk about serious illness communication, it really can, the center of it is patients, but it also is the people surrounding the patient. So the caregivers, the surrogate decision makers, the healthcare proxies. So as we're thinking about these communication skills, knowing that in geriatrics and palliative medicine, that when we're taking care of patients, we're also taking care of their entire community and friend. And so oftentimes we're not having these direct conversations with patients, but it can be with people that are very important to them. So I want you to take about 30 seconds and think about what makes communicating serious news hard. So take about 30 seconds, write it down or put it in your phone or on a piece of paper if you have paper in front of you, to just try to think about what makes communicating serious news hard. So a lot of people say what makes communicating serious news hard is, they don't want to trigger any emotional response in someone else, that, they're scared of emotions that may come up, feeling guilty or frustrated, or feeling frustrated, or also just feeling like you don't have something to offer after newses. And so hopefully by the end of the session, you'll have kind of some roadmaps or tools in your toolkit of how to make this a little bit easier. So 98% of clinicians say they want to have goals of care conversations, but only 14% say they have goals of care conversations. So there's a disconnect with medical providers that they want to do this, but they're not doing it. And so why are they not doing it? A lot of people say they don't have time. They're not sure when to do this or have the conversation, unsure what to say, don't know what other team members have said. They might not have formal training about it. Their desire to maintain hope or uncertainty in estimating prognosis. That makes this particularly challenging. So most people with serious illness want to talk to their team about what to expect. So we know clinicians want to have these conversations, but aren't having them. And we know that patients with serious illness want to have these conversations. In a qualitative study with 179 surrogate decision makers of ICU patients, 93% of surrogates felt that avoiding discussions about prognosis is unacceptable way to maintain hope. And they said that information is essential to allow people to prepare emotionally and logistically in someone's mortality in the future. A lot of themes that came up was that there was aversion to creating false hope, which I think sometimes is the goal of not talking about. We don't want them to give up hope when we have these conversations. Some clinicians feel worried about that. But oftentimes people want to know the truth and are seeking for hope elsewhere. So it's interesting, in another study, when we ask families and patients, who should be having a say in decision makers about their treatment, they really want it to be about themselves, the patients or the family. And when people are asked with serious illness, is it important to emphasize hope or more to be honest? The vast majority said, 88%, that they want people to be completely honest. So we know that patients want it and families want to hear this information. They want to be having the decision making and kind of be in the driver's seat of making these decisions. And they want the honest truth from family or from clinicians. And so why does this matter? We know that when we communicate effectively and when we have, conversations about prognosis and plans of care, it leads to decreased family burden. It leads to improved family satisfaction, which I know for many centers is a huge quality metric marker. It leads to improved bereavement outcomes, lower costs of care, and it helps patients and families select medical treatments and care settings that meet their goals. So really trying to get at treatment goal concordant care. I want to take a little step back. I know we defined serious illness, and I know you guys had a previous session in the CME course about advanced care planning. I think sometimes there's some confusion between advanced care planning and serious illness communication. And so I just wanted to kind of emphasize that there's a lot of overlap between the two, but there is slight differences. And so when we talk about advanced care planning versus today, we're going to be emphasizing serious illness communication. I want to really hone in so we're all on the same page. So advanced care planning is the definition is completion of advanced directives, relatively healthy adults, and it's plans for the future. So it's showing that people are healthier and what they want in the way future. Whereas serious illness communication, the definition is it's structured conversations between clinicians and patients with life-limiting illnesses about values, goals, and care preferences. And it's more in the moment conversations, and it's repeated conversations over time, as we know that oftentimes as people have more disability or as they're going through a serious illness, their goals and their wishes change. And what someone may want in a month is very different than what someone may want now. And so having these repeated serious illness communication conversations is really important to have real-time understanding of what is important to the patient, knowing that it can change and not assuming that, a document that was written 5 years ago is the exact same wishes that they want. Sometimes those documents can be helpful if someone has something like dementia to extrapolate what may be important to them. But again, emphasizing that as people are living with disability or serious illness, their goals and preferences may change. And it's really important to understand how the values and goals and preferences are in that moment and making decisions in that moment. There's a lot of literature and discussions in the geriatric and palliative care community about kind of advanced care planning, serious illness communication. So if this is a topic of interest for you, kind of comparing the two, I recommend you looking in the literature to listen to kind of some of these conversations that's been coming up in the field in the last few years. So the good news is you might be thinking, hey, I'm not so good at communication. I don't know what I'm doing, but it's something that can be learned. And you may say, I'm already really good at communication. I've been doing geriatrics and palliative care for many years. And the good news is you can always go from being good to being great. And really, hopefully, this will be a roadmap for also teaching others, whether it's, team members that you're working with, or it could be also colleagues that are consulting you how to have some of these initial conversations and spreading kind of the word about primary palliative care. So the hope is that, like any skill, communication skill is something that can be learned, and that we're hoping that the toolkit that you learn here today will help you be able to help pass this on to other people. So there's various clinical tools for serious illness communication. One of them was called Spikes. That was initial framework many years, and I would say elements of that is helpful. There's been other models with Vital Talk and Serious Illness Conversation Guide. For those that are not familiar with Spikes, it's an acronym that kind of goes over the framework of how to set up a meeting. So the S is kind of setting, making sure that you're finding a quiet space, having the right people there that need to be part of the conversation. P is perception, asking what the patient or whoever you're having the conversation with, what their perception is. I is invitation to share information. And then K is sharing that knowledge. E is addressing emotions. And S is summary. And that a lot of the core elements of Spike, I know we went over it very quickly, are incorporated into what Vital Talk has used since its inception. And today we're going to really focus in the next half an hour or so about talking about a Vital Talk framework that I am hoping that you guys will pick up and utilize in some of your conversations. So that framework that we're going to be talking about is something called REMAP, or an acronym, because in medicine we love acronyms. And it's for Goals of Care Conversations for Serious Illness Conversations in real time and at different points. And so the hope of this reframe or this Vital Talk framework is to assess perceptions of illness. It elicits communication preferences, it delivers the clinical information, and it attends to emotions. So this is a roadmap that can be used at different touch points. So we'll start with the beginning in terms of reframe and in terms of reframe and expecting emotion. So the first part about reframe is introductions and agenda setting. And so why do we even start off with agenda setting? And the important part of it is because we want to help prepare patients for the future, and we want them to reprioritize their goals wherever they're at. So it may be, knowing that, so you do introductions with everyone, but knowing that you just were diagnosed with cancer, is it okay if we talk about what next steps may look like or how to move forward? Or knowing that you've had this cancer for many, many years, you've been through different lines of treatment. Would it be okay if we talk about what to expect moving forward? And so that conversation and that anchoring point of agenda setting is really important, because you're going to have different timeframes of these conversations, and knowing that the needle has moved and that things may be different at that point will ground you in the whole hope of the meeting, and knowing that it's different than the last conversation. And I will say that all of these conversations are iterative. It's not a one and done conversation. And so agenda setting can be really helpful of saying why that particular conversation may be different compared to the last conversation. That, time is different, or I'm seeing you in the hospital. This is not the clinic anymore. Things are different. So that agenda setting is very important. So the reframe part, in order to make plans about the future, people need to know where they are heading. And so the R and the REMAP framework is communicating, is the reframe. So communicating the serious news and ensuring you're on the same page. And so there's another algorithm or acronym that we use in terms of ask, tell, ask. And so we're going to go into more detail of what that means. So in the reframe, it's important to start off and say, what have you been told so far? And the reason that we do that is because we don't want to assume what people know. And so we want to know what the latest they've heard, or if they have a sense of the big picture. Some people are very up to date, and some people, it's hard to, when you're having emotions, it may be hard to retain some of the information, and they may need to go over what that key information is again. It's also a really helpful question if there's multiple people in a conversation, because not everyone may be on the same page. And if you have a family or a patient with a family that is really large, it may be that, the 10 siblings aren't on the same page, and 2 have been hearing the information, and it's a telephone game. And so some of the other ones have really only heard that their mother is in the hospital. And so if you have a big group, it's also really helpful to elicit that question from multiple people to see if you need to take a step back, and to see if you need to kind of go from the beginning if everyone's not on the same page. And then the second ask for ask, tell, ask is it okay if I share information? Oftentimes, whether you're in the outpatient or inpatient setting, patients, family members don't really have control over much, and especially in the inpatient setting, patients are woken up at multiple times. Their blood is drawn, their blood pressure. Someone comes in and say, "Hey, I need to check your blood pressure." There's a lot of pressures in terms of rounding and when clinicians have time to come into the room. And so a lot is out of their hands. They don't even in the hospital have a say of when their food is delivered, if it's warm or cold sometimes. And so really giving some of that agency back to patients and or family members can be very important. One, to see if they're in the headspace to hear this information. Two, to give a sense of control of a situation where a lot of control is not there. And if the answer is, if there's any hesitation of sharing information, or if there's a no, that's your sign that they're not in a headspace to hear this information. And I would take no or any hesitation as a no, so that you're really pausing and not sharing information when patients and or families are not ready to hear them, or chosen families. So then the next step is sharing the information. And we use the phrase headline for it, but really it's just sharing the clinical information or main message. And there's two really important aspects to it. You want to clearly give the medical information and convey what it means for the patient. So with this headline, you're really succinctly reducing the information to 1 to 2 phrases, as we know that there's a lot of clinical information that can be given. However, if it's a huge paragraph, people aren't going to retain the main message, or they're going to pick out what they want in the main message. And so it's really important to give a succinct headline that really captures the crux of what you're trying to say. Usually we give like a paragraph or, a 2-minute spiel about what someone's medical condition is. And then at the end of that, we give the crux of what this really means. And so we're kind of asking you to flip it around by giving the main message and sharing what it means, so that then you can have them process that initial information, and you can answer questions later on in terms of more of the logistics and details. So an example headline is, unfortunately, the bone marrow biopsy shows that the cancer is back. And what that means is it's no longer curable. So the cancer is back is the main message, and the meaning is it's no longer curable. We want to give these phrases in again, avoiding medical jargon and succinct, simple language to about a 5th grader education level, as that's kind of the common denominator for the patients and the people that we're interacting with. Another example of a headline is, your mother's infection is severe and she's having trouble breathing. I'm concerned that this means she may need a ventilator. So she's having trouble breathing and her infection is very severe, which means she may need to be intubated shortly. Or another response is that the biopsy came back and unfortunately it shows that you have breast cancer, or so that is showing that the biopsy is back and the meaning is that they have cancer. So remember, we're in the reframe part, we're doing ask, tell, ask. So the second ask depends on kind of if you're in low stakes or higher stakes situations. So say you're in the clinic or even in the hospital setting, and you've shared some medical information, and so you could do the teach back, which some of you may be familiar with, to make sure I did a good job. What will you take away from our conversation? And really putting it back on you, not to make sure I know what you understand or as a quiz to them, but really to make sure I did a good job. What will you take forward? Or checking in, this is a lot of information. Would it be okay if we start talking about next steps? And again, if the answer is any hesitation or no, that's a red flag, and that's to pause the conversation. Or, this is a lot of information to process. I'm wondering if we could pause here, and if I could come back in a few hours, or if we could set up another outpatient meeting in maybe a week to kind of process what information was shared. Or could the social worker or chaplain call you tomorrow to check in to see how you're doing with this difficult information? So the next part of the remap is expecting emotions. And I would say that emotions can come up at any point. So when we talk about this emotion aspect, although it's the E in remap, it really can be applicable to any conversation at any stage. But we know there's been a lot of literature that emotion, if you share information and you see an emotional response, it means you successfully conveyed information. They heard the medical information you're sharing, and it's normal and expected to have emotions when you're sharing really hard news. So if you are seeing emotions, that's a sign that you were effectively communicating the main message. We also know that emotions shut down cognition or ability to process information. So you may be like, I spent an hour with a patient talking about the diagnosis of dementia, and they came back to the next clinic and didn't remember anything I said. And that's really common because if people are hearing information and they are emotional, they're not able to process any details of what the dementia means because they're in their emotion mind and they're kind of doing circles or spinning in their head and feeling overwhelmed. So it's important to pause and recognize these emotions so that we can give either more information or that they can process what's happening. And I will caution you that sometimes emotions are masked in cognitive questions. So it's natural for people to say, well, can you just repeat the scan? Or can you get another biopsy? Or are you sure? Can I get a second opinion? And while it's easy for us to kind of just jump in and repeat, I don't think another biopsy or another CT scan will show anything different. The crux of that question is often an emotion. And so addressing that emotion can be really helpful to answer the question instead of going into more medical information and getting the patient or family member more lost or shutting down kind of processing any information. Emotions come up, like we said, at any point. And so it's important to kind of be aware of them and know that they can come up and respond to them at any point. I want to emphasize when we're talking about emotions that we're not trying to change these emotions. We are not trying to fix emotions or stop them. It's really giving space and time for these emotions to be processed, to recognize, and to listen to them. It is not our job to insert our own assumptions on how someone's feeling or how they should feel. It's really giving people space to share how they're feeling and time to reflect the information that you shared. So an acronym that we can use for responding to emotions is NURSE. And so we're going to quickly go over that acronym. And this is, again, a toolkit. So you may have heard this before. You may think, if you have heard this before, I'd like you to kind of reflect and say, okay, these are the ones I gravitate towards. What are ones that I don't use, and how can I intentionally practice those? But going over the NURSE statements, the first one is name. So that is naming the emotion. You seem upset. You might not name the emotion correctly, but that always gives you data points on how someone's feeling. And so they may say, no, I'm not upset. I'm really disappointed, or I'm really frustrated. I've done everything I can. How can my cancer be progressing? Understand is obviously none of us can put ourselves in the shoes of a patient or family member or caregiver. And so we want to avoid saying that we understand, but we want to show empathy by saying, I can't imagine how difficult this is, or I can't begin to understand what you're going through. Respect is one of my favorite ones. I think oftentimes in medicine, we focus on what patients haven't done, or kind of, you didn't show up to your appointment, you're late, or you're not taking medications. But so many people are trying their hardest to show up and be present and try to get better, and they're seeking you for help. And so showing that, I can see how hard you've worked, you've been at every appointment, or I know that you've been through so much in this hospitalization with allowing all of these blood draws, with allowing all of these tests to kind of get to the bottom of what's going on. Or if it's for a caregiver, I can see how much you care for your mom or dad. You've been at his or her bedside every day. Or, if it's a caregiver or a home health aide, like, I see how you're showing up and you're coming to all the appointments. It's, this person's so lucky to have you as their home health aide. So really honoring and respecting the caregivers that really support the patients. Support is the next part of the NURSE acronym, and that can be helpful in saying alignment with your team. We're in this together. in current medicine, it is really a team sport. It's unrealistic that we will continuously see a patient, even if we're in clinic and longitudinally seeing someone. Maybe there's an urgent visit that someone else is seeing them, or if they're in the hospital, it's a colleague that is seeing them. And in the hospital system, we know that there's a lot of handoffs. So maybe saying, I might not always be here. However, our team is here to support you. It may not be me, but someone will be here to walk you through each step of this diagnosis and what to expect, or walk you through this treatment. Explore is another favorite one of mine. That can be really effective one if people are asking a question and you're not sure, is this cognitive or is this emotional? And so you could say, if someone says, well, are you sure or something? This must be wrong, or I don't believe you. You could say, tell me what's concerning you, or tell me what's behind that statement or that question. And it oftentimes opens up of what's really underlying the crux of the emotion. And if you kind of ask me, tell me more a few times, and they're like, no, I really just want to know, can the CT scan be repeated? Then that's a sign to you at that point that maybe it's transitioned from that emotion to cognition. But unless you explore, you won't know, and we don't want to make assumptions. Okay, so silence is another effective way to respond to emotions. It gives patients' families space to process information, and it allows them to be the ones to speak. We know with research that when patients and families speak more than clinicians, they often find that they've been heard and understand the information more. It also, if we're feeling really overwhelmed as the clinician giving this information, or whatever our professional role is, it can be a chance for us to regroup and be like, what do I want to say next, or what is my next phrase? And so it can also be a pause for you intentionally to be able to kind of regroup, especially if you're like, wow, I just shared really hard information and I'm feeling emotional. So giving yourself time to take a deep breath. Another really effective way to respond to emotions is I wish. I wish I had different news to share. I wish we had a cure for the cancer. I personally use I wish when I'm like, oh crap, I have no idea what to say. And so it's a good point to show that you're having empathy and you're relating, and you really truly wish that things were different. It's helpful if you are someone that tends to say I'm sorry, or have a tendency to say I'm sorry. It could be a helpful kind of trend phrase to substitute instead of saying I'm sorry. And with any of these phrases, whether it's a nurse phrase or the I wish, it's important to avoid saying but after it, because we don't want to negate the work that we're saying before and the alignment we're making with patients and their support network. So we don't want to say, I wish I had different news to share, but no, your loved one is really in the active dying process. We don't want to, again, negate what we're saying. So I wish that I had different news to share, and I'm very worried that your father or your mother is in the dying process. So it's very different when we use and when we avoid that but phrase. Another a way to support people in their emotions is to show gratitude. Thank you for sharing that. Patients and families, when they have emotions, are showing their vulnerability. We often see people in crisis mode. And so in order to build rapport and trust, showing gratitude can go a long way. So I encourage you to try it if it's not something that you commonly do already. Whenever you have a nurse phrase or respond to emotion, I encourage you to say one phrase and stop. There was a study that was done that showed when clinicians attend to emotions and stop, families or patients have more time to express their emotions and provide valuable information. If we keep going, it's negating the fact of pausing for that emotion to have time and space. And so it's really important to not keep talking, and to really give pause along the way, and to keep the conversation person-centered and keep it efficient. So how do you know if you've given information, if you've responded to emotions? How do you know if you can move on in the conversation? A good question is, would it be okay if I ask you some questions to help us know what's most important in moving forward with your care? or given with what information I share, now that you have a dementia diagnosis or a cancer diagnosis, or that your loved one is, on 3 pressors in the ICU, would it be okay if we talk about what's most important at this time? And again, that's where the serious illness conversation comes in, is anchoring at that moment in time so that we can make treatment plans with that current clinical situation. Again, if the answer is any hesitation or no, that's your cue to say we're too much in the emotion mind and processing this information, that now is not a good time. And so the second half of Reframe is that transition point to mapping values, aligning what's important to patients, and coming up with a plan. And why do we do this? Instead of asking a menu of, would you like to be DNR? Would you like to be DNI? Would you like to have antibiotics? That can be really overwhelming for anyone to have a menu of treatment options. And at the bottom line, patients and families care about outcomes. They care, how long am I going to live for? How am I going to feel? Where will I spend my time? How will I spend my time? And so oftentimes people will say, being able to interact is really important, or being free of pain. And you, as the medical team, can really say, okay, based on what I know medically, what's going on, and what that patient's future may look like if we do this treatment plan versus this treatment plan, it allows you to really give a recommendation based on patients' values and based on the outcomes that the patients are hoping for. So how do we get at what's important? Again, we have another acronym that's called values, and that is getting at really what's important to patients and families. And so, there's different questions about values that can help you understand what outcomes are most important. So again, this is a toolkit like NURSE statements that you don't have to ask all of these questions, and you don't have to ask them in a row, but it's a way of getting at what's most important. And I highlighted 2 of the questions that I highly encourage you to ask for every patient or every family member of, given this news, what's important to you? And looking forward, what worries you? And again, it's really important to anchor with any of these questions, why we're asking these questions, not just say, can you tell me what's important to you? But given what we shared, or given that time may be short, or given this uncertainty, with this frailty in your spouse or in your mom or dad, what worries you? Or are there any treatments or ways of living that would be unacceptable? So you guys will have access to these slides. You don't need to memorize these acronyms, but I just want to emphasize that when you ask these questions, it's really important to provide the context of why we're asking these questions, to know where we're going. And because again, like we said earlier, people's goals and what's important to them change. And someone may say, I never wanted to, be dependent on someone. And if they had a stroke and they, now need help or can only be in a wheelchair, but they still have conversations and may find that meaningful at that point in time. And so it's important to say, given your stroke and the rehab where you're at, what's important to you now at this point, as things can change. And again, we don't want to make assumptions. It's really important when we ask these questions to ask what else. We don't want to just say what's important to you and say, okay, we're done, we figured it out, because people often share what's most important to them after a while or after asking. So asking what else allows you to uncover most values. And sometimes the crux of what's really important to people or what they're really worried about comes out after asking what else 2 or 3 times. And so again, you don't want to ask these questions before just once and say, I'm done. I recommend with any of these that you ask at least kind of 3 categories to make sure we're getting a really holistic approach of what's important to patients and making sure that we're getting, if we're not talking to the patient themselves, we're really getting a sense of who this person is and what's important to them as they're not able to talk to us. These questions can be asked, what is important to you, or making sure that we're bringing the patient into this conversation. So if you're talking to someone's partner or spouse or surrogate or healthcare proxy, it's important to say, what would be most important to Bob at this point in time, or what would be most important to Jessica at this time. So making sure you're bringing that person's voice into the room. How do you know if you're done mapping values? Oftentimes, patients or families will repeat themselves. They can't think of anything new, or you've had enough information to kind of figure out what are the three buckets or what kind of care plan am I going to recommend? Because the whole hope is to get a sense of what's important to patients so that you can have a sense of where you're going or what you're going to recommend. So the three main buckets I would say is continue all life-sustaining interventions, trial of critical care. So, we may try this, and if it doesn't work, then we will kind of shift care plans. Or the third bucket would be comfort-oriented care or symptom-focused care, and really sometimes emphasizing quality over quantity at that point. So if you've asked enough questions and you're like, I think I have a sense where the treatment plan will go, then you'll have a sense that you've asked enough questions. And so what do you do at that point? We're going to go to the A of remap of aligning with shared values. And so you repeat what you've said. So reflecting back values shows that you're listening and ensures that you got it right. And so an example can be, it sounds like being at home is really important to you, being at, having time with family, that you've been back and forth from the hospital and that's been really cumbersome to you. And that it sounds like you haven't enjoyed being in the hospital lately, or it's more disorienting. Is there anything else I missed? Or did I hear you correctly? To make sure that we're not, again, making assumptions, and that if people, may have meant something else, that we're getting a sense of what they meant and having a chance to correct it as well as add anything. And then since you've done all that hard work, it's time to propose a plan. And so there's parts of the plan of asking for permission, again, checking in to make sure it's okay, time and space to ask that, and to propose a plan. So when we propose a plan, we want to say what we will do before we say what we won't do. And that's important to show that we're listening and we're not abandoning someone, but there's always something we can do no matter what the care plan is. And then checking in and saying, how does that sound to you? So an example may be, I recommend that we add a care team that will help manage your symptoms in your home and offer support to you and your family. This team is called hospice. That may evoke some emotions, so maybe pausing and hearing how their response is to what you will do. And then you can also say, I also recommend when the time comes and your heart stops, that we allow you to die naturally and not place you on a breathing machine, because this would mean that you'd have to go back to the hospital, which is something you said was not acceptable for you at this point. And then again, checking in, how does this sound? You may get people that disagree with you. And I would say that is an opportunity. Instead of being like, crap, I messed up, it's really an opportunity to be curious and say, okay, where is the disconnect? Again, we don't want to make assumptions, but we want to ensure that patients and families are heard, and be curious and say, what is going on here? Some of this may be that not everyone is comfortable with the care plan, or there may be some disagreements between families or patients and families. And so there may be some conflict. And if there's conflict, again, I would encourage you to be curious. What is the source of the conflict? Is it guilt? Is it grief? Is it culture, religion that's underplaying this? Is it some family dynamics? Is there mistrust of the medical system? And so it's important to clarify any misconceptions at this time, and maybe to set time-limited benchmarks of, it sounds like we're not ready to really make a decision. Let's take the next 2 days and set goals. Like if we see improved oxygenation, that may be a sign that we need to give someone more time. Or if we see that someone is more and more dependent on this breathing machine, maybe it's a sign that they're not getting better, and that would give us the clarity we need. Goals of care is a process. It's not an isolated one and done conversation. And I truly believe that each conversation allows us to get to the next point. And so that whenever we have these conversations, it helps us prepare for the next conversation. You may not be the one having all of those conversations. However, you are helping your either future self or a colleague get a sense of what is important and move the target to make sure we're giving patient-centered care. We don't have time to go over, and I don't want to go into as much detail about the serious illness conversation, but I just want to emphasize that it's really talking to the patient, and it's a lot of some of the same skills. They have a lot of resources online, so I encourage you that if you feel like this is a helpful model, to look through it. But it's really looking at, would it be okay if we talk about conversations? What's your understanding? Sharing information, and then also, what's important to you. So it's a different framework to ask some of the same questions, and it's a resource online that's available. And then, coming up with a plan or summarizing for the serious illness guide based on the same hard work that you did. Okay, so where do you go from now? How do you get better? And so there are a lot of resources out there. If you haven't heard of Vital Talk, there is the website has other courses, but they also have communication guides or toolkits that can help you kind of learn some of these phrases to say. And they also have an app that you can download, and you're like, oh, I don't know what to say, or I need a little cheat sheet. The Center to Advance Palliative Care, or CAPC, has a lot of modules on communication skills, so I highly recommend that you go through them. And then again, the Serious Illness Care Project is another resource. Again, these are just 3 of many out there. There are a lot of tools to share this or to teach these skills. So it's not something you have to learn on your own or, create ground up if you're trying to teach this to other people. Utilize the resources that are out there. So I want you to think in your current clinical role and setting, how you imagine applying these skills. So take maybe 30 seconds to write down how you can apply these skills and what's something you may commit to in the next week, because we always want to be deliberate when we're learning new skills. So write one thing down, or text yourself or email yourself to hold yourself accountable. Okay. And with that, just to emphasize a few take-home points that, you want to invite people into these serious illness conversations. If people aren't ready for it, please respect that. Pause, let patients and families share, their emotions that may be coming up and what's important to them. Respond to the emotions, hold space for it, and make recommendations that are based on patients' values. And with that, I have a bunch of references, but I'm going to turn it back to Molly to see what questions we have.
Excellent. We have a couple of good questions in the chat.
Great.
So I will start with Dr. Peleg, and I think this one came in the mapping section, so it might be relevant to that. What do you do if someone is not really giving you any information when you're asking these questions? That's definitely happened to me. I don't know if it's happened to you.
Yeah, it definitely has. And so again, with these things, whether they're disagreeing or they're not giving information, I would kind of be curious. I would think to myself, is this because they're not in an emotional space to hear it? Is it something that they've never thought about before? Do they want other people present with them when they're talking about this? So just, if they're not answering, just saying, have you thought about this before? And if they say no, then say, I'm going to give you some time and space to kind of think about these things, or, process it. Would it be okay in the inpatient setting if I come back in a few hours or tomorrow? Or is it okay if we bring this up in the next clinic visit? I would also, encourage, as there's someone else that you want to be part of this conversation, or really say, I see that this is hard to answer right now. Can you tell me what's making it challenging? So again, just be curious and explore, because it could be that they're too emotional. They've never thought about it before, or, that for whatever reason, that this hospitalization might not be the time that they want to really open up. I will say that there are certain patients that really have a lot of anxiety when it comes to their own mortality and may not tap into this. And so it may be that they can't talk about these things. And so maybe getting a sense, would it be okay if I talk to your spouse or your daughter to learn a little bit more about you and just figure out how we can best support you? So maybe opening that up to someone else to figure out what's important to them if they feel like they're not at a place to open up.
I love that. Okay, next question. Can you say more about emotions being masked as cognitive questions? It feels weird not to answer the question.
Yes, I agree. When I first started doing this, I was like, we're trained in medicine. Every question we get, we need to answer, and we need to answer with medical information. And so I think, again, it's not that every question you get asked, you need to say, tell me more about it, but it's really getting a sense of, is this question, especially after you've shared serious news or news that is probably emotional or hard to process, it's really important to pause and really say, okay, are they asking me, are you sure, or can't there be another option? Are they asking me that because they're scared, because they're afraid what's going on, because they can't believe this information? So really exploring will allow you to get a sense of if it's emotion or cognition. If they really say, no, I really want to know what the white blood cell count is, then you're like, okay, I've done my assessment and I've said, okay, this doesn't seem like emotion, but at least I've given them time and space to express that. They really do want to know the cognitive information, so I'm going to jump into it. So it's not that you won't necessarily give the information, but you're just slowing the conversation down a bit more to really see, is there emotion behind it?
I love that. Okay, one more question. I remember learning the SPIKES acronym. Can you comment on why it fell out of favor and we have this new acronym?
Yeah, so I would say there's elements of the spikes framework that it can be very helpful. I would say the remap really incorporates a lot of elements of the spikes. However, remap, I would say, is a little bit more patient centered and allowing you to be able to kind of get at the crux of what's important to patients and get really their treatment values.
Thank you so much for joining us this morning and getting us started for day 3.
Yeah, and if there's any other questions, I'm happy to answer them via email, or please reach out. Thank you, everyone. Take care.